Thank you, everyone, for coming this afternoon, staying awake. I hope your coffee is working, is keeping you up. And thank you to the organizers for inviting me to speak. I'm going to try to touch on a few points today regarding and to tie in a little bit to some of the elements that were discussed this morning by other excellent speakers, namely, how do we create relationships of trust with patients who are sometimes the patients that we dread seeing in our offices. As we saw today, you know, some of the terms that caused us anxiety were borderline personality disorder, patients with a lot of somatic complaints. I would say as a general neurologist, between 40 and 60% of my practice consists of patients with various psychosomatic complaints. And I'm going to talk a bit today about functional neurological disorder and essentially how we can avoid pigeonholing people, but how we can also create trust relationships with them to have them avoid physician shopping. So I'm actually going to try to tie in a lot together today in order to, for a patient population that I actually find very endearing, for whom we can help a lot, and who is a very interesting, heterogeneous but interesting patient population. I don't have any conflicts of interest, no financial disclosures, nothing. I'm going to speak very briefly about two cases, 2 out of the 3. And we'll go very, very briefly over the history. Many neurologists, not most, but many of us are history nerds. We'll talk about the DSM-V very briefly, assessments and treatment approaches, and then conclude with the cases again. You can keep going, it's okay. In fact, I'm not going to touch about case 1, I'll do case 2. So case 2 is a 56-year-old woman of Tunisian descent, a single mother, 2 daughters, teaching French as a second language. She'd had 2 deep vein thromboses and was on warfarin. And the first time I saw her was about maybe 8 years ago. She'd had what looked to be like a convulsive syncope, so low blood pressure, caused her to have some tonic-clonic movements. And a colleague of mine had started her on levetiracetam, an antiepileptic. She persisted to have reported absences where she would be not participating in a conversation, despite adequate doses of the medication and a good tolerance to the medication. And most of the time when I asked, I'm not sure how I ended up following her, but most of the time I would ask that she be accompanied by a family member. Didn't always happen. Her daughters were in their late teens and had lives of their own. She had a couple of EEGs, and some had some very small, mild abnormalities, but she continued to have what we called absences. Then she began complaining of proximal muscle weakness as well. I continued to follow her. Let's go back one more, please, thanks. Again, yeah, fabulous. As I continued to follow her, she started to have memory complaints and fatigue, very sort of non-specific things. She didn't drive. She seemed to be able to get up the stairs in the metro, but constantly multiple complaints. And then she stopped coming. She had an EMG. I wasn't very convinced that she had a muscle disorder. I sent her for a second opinion to a tertiary care center. I got back that the report was normal, and then she just disappeared completely. She was worked up. She had normal biochemistry profiles. I mean, I really made sure that I did my due diligence, and I was pretty convinced that this was a somatic issue. We'll discuss the diagnosis in a minute. About 2 years later, I got a call from the CLSC, which is our sort of home care linking network, asking me what her diagnosis was, her medical diagnosis. So now she's 58. The family physician who is now following her was trying to prescribe a hospital bed and a manual and a motorized wheelchair for her, which many of my patients with true organic neurological diseases have trouble getting. And I said, no, she doesn't need those things. She has a functional neurological disorder. So that's my case 2, which we're going to discuss a bit more. Case 3 was a 43-year-old woman living on welfare with 2 of her 3 children. Each one was from a different father, and she had been living with a boyfriend as well. She had acute onset hemiparesis, so paralysis on one side of her body. It happened to be the left side of the body, with speech difficulties upon awakening from an anesthesia for a breast surgery. A colleague of mine thrombolyzed her, so gave her a clot-busting drug, because she'd also had a history of a sister who had a stroke at the age of 39, and honestly, if you follow the protocols, then it's better to thrombolyze somebody who in fact did not have a stroke than who did have a stroke, if there are no contraindications. That's precisely why this protocol is created. This lady had irregular symptoms or irregular signs, so she didn't look like a typical stroke even after the thrombolysis, which made us wonder, after the fact, the other colleagues who were around, why was she thrombolyzed and what else was going on? In fact, she had neurological findings, which makes seeing patients with mental health issues more of a challenge, because it's hard to sometimes divide what is a neurological problem and what is a psychiatric problem. But certain elements of her physical exam certainly made it more evident that there was more than just a neurological problem going on. As with many neurological problems, there are sort of consistent elements of a neurological exam which help you identify when a patient has a particular pattern of disease, and it helps you then come to a conclusion about that type of disease. When there are irregularities in a neurological exam, then you have to start thinking outside your box and think more widely. It's okay, I'll talk about that after, actually. Yeah. So in the 2 cases, case 2 and case 3, both women had irregularities on their neurological exam, had irregularities in their history, weren't necessarily coming forward with everything that we would have asked, and in fact, both had what we call functional neurological disorders, which were previously called conversion disorders. Initially called hysteria, then called conversion, sometimes called somatization or psychogenic. So somebody talked about pseudo-seizures earlier this morning. The new terminology from the DSM-V, which is the psychiatric Bible, is a functional neurological disorder, and it doesn't presuppose an etiology, which I think is the most important element. And it's important for physicians to recognize that we don't presuppose an etiology in order to be able to create a link and a relationship with the patient who might otherwise be a very frustrating patient. Because you say, this lady did not have a stroke, why is she paralyzed? Get out of bed, walk, take care of your kids. Why are you getting physio? Why are you getting rehab? You're going to an inpatient rehab. Why? You did not have a stroke, right? Get up, move your butt, go, And it can be very frustrating and very challenging for the caregivers, for the nurses. I mean, these are people who can sometimes be on a bed in a ward for weeks and months. It's really surprising to see how other caregivers respond. I won't go through all the history because I really do want to allow my colleague to talk about it, but there's some beautiful literature from Charcot, and then from Freud. I love this picture. It's such a classic, but then I found it with all the names of everybody. on it. So Freud was a initially a neurologist, did a fellowship with Charcot, and his initial theory was that physical symptoms are the result of a sort of a conversion or a repression of a painful experience. And I think that with time we've moved away from a simplistic analysis like this, although sometimes we can find certain elements. So this morning, for example, when Karan discussed the lady having a difficulty going through a doorway, I wanted to know, in fact, has anyone explored what doorways represent to her, what they mean? Did she have any traumatic experience with a doorway? We see it sometimes with Parkinson's patients, but sometimes there's more. Okay, go on. And then as the notion of hysteria evolved, in the 20th century, psychiatry and neurology diverged, which I think is actually a relatively unfortunate thing. But then they sort of went through, we've talked a bit about war this morning, and there have been studies done on soldiers and soldiers returning from war. There also became a larger discussion about malingering, so creating or mimicking abnormal symptoms or signs in order to obtain the benefit of having a label of a patient, which is also distinguished from more of a factitious disorder where you're trying to get a secondary gain, either insurance claims, where you're getting some other benefit aside from just having the label of a patient. In the middle to late 20th century, the introduction of the idea of a biopsychosocial assessment came to the fore. And in the 1980s, even something was described as la belle indifférence, which was associated for the first few times with functional neurological disorders, where a patient may have a very severe symptom or very severe sign, so being completely paralyzed on one side of their body, but doesn't seem to be at all panicked about it, which when you look at somebody, it becomes very surprising. You can't get up, you can't walk, you're 43. Why aren't you panicking? Why aren't you crying? Why aren't you scared? Why aren't you... So in fact, we do see it in other diseases, and so it's not typical of functional neurological disorder. We shouldn't pigeonhole people just because of that. So in fact, it's not a diagnostic sign of functional neurological disorder. In the 1980s, other evolutions in the history of this investigation, you started having video EEGs, so people who would get EEG leads all over their head and a video, and then you could actually see if during what looked manifestly like a seizure, shaking and moving, was there a correlation on the electrical activity of the brain? In the late 1980s, you also had much more investigation and study of what we call psychogenic movement disorders. Thank you. In general now, as was a bit discussed this morning in other fields, there has been a lot of resistance towards following patients with functional neurological disorders, and it can lead to patients shopping around quite a bit. If patients don't feel that they were able to establish a relationship of trust with a physician, and if they were just told simply it's all in your head, they often go from one physician to another, to another, to another, and they never actually get their real problem addressed, which is, to their detriment. They often, I've had patients with what we call paroxystic non-epileptic seizures, so now are called PNAS, but previously called pseudo-seizures, who are 19 and 20 and who've gone from ER to ER and to ER and have had episodes, and they get scanned. So 1 scan, 2 scan, 3 scans, 4 scans, and it's a bit ridiculous where, nobody's actually sat down and said, okay, well, let's find out how we can better address this. Have you ever been referred to a psychiatrist? Have you ever been referred to a psychologist? Have you ever had a multidisciplinary team where we all sit down and try to address the underlying anxieties or fears, etc.? So we moved away from former and previous diagnoses, terminology. And I think one of the nice things about the DSM-V, even though they've complicated the title or the terminology to functional neurological disorder rather than conversion disorder. The DSM-5 emphasizes the need for a proper physical exam, a proper history, proper completion of ancillary testing when necessary. And it remains a diagnosis of exclusion, but one that I think still needs to be there lingering in the back of people's heads in order to avoid patients from not actually figuring out or finding out what they have. So in fact, it's quite a complex diagnosis, and there's many different variants and subtypes. So I won't go into all of them, but essentially as a diagnosis, it's one or more symptoms of altered motor or sensory function, clinical findings that are incompatible with a neurological diagnosis, symptoms that are not best or better explained by another either mental or medical disorder, and that cause some sort of distress or impairment in function. I won't go into all the subtypes, thank you. Interestingly, and one of the things that I love the most is the neurological exam. It allows you to really be a detective when trying to find out what's going on with a patient. Some of the most interesting ones are astasia, abasia, and this is where I'm very happy to know that Karan is around. It's when a patient has tremendous difficulty walking. They could be like a Leaning Tower of Pisa on one side and stumbling to the left and stumbling to the right and tippy-toe and heel gait, and it's all sorts of complicated patterns, but they never fall. They say they fall, but they never fall. So that's often one giveaway, which medical students love to describe, and then you go, no, it's okay, let's watch the patient walk. And all sorts of other little things that can come up. Oftentimes, listening to the patient offers many clues into the underlying cause of their distress. So just sitting down, making a comfortable space at the patient's eye level, and listening to the patient and saying, what's going on? What were you doing? What happened before all this happened? What were you doing? Who was around you? Who was home? Had you spoken to anyone? Did you have any distressing discussions beforehand? Who'd you talk to? Right? Often gives you a really nice idea of what was happening. For pseudo-seizures, you could ask questions like, were you able to hear anyone talking while you were having this event? How did you feel? Not to sort of presuppose when they said, no, I lost consciousness. Okay, but did you hear anything while you lost consciousness? You give them the open door to be able to express themselves better, and they may describe depersonalization or derealization, a feeling of being out of body, which allows you to sort of get this idea that something happened. They were not comfortable with what was going on, and they sort of shut themselves down. So there are certain things that put patients more at risk for a functional neurological disorder. And it's nice actually to have somebody who does pediatric or adolescent medicine, because you probably see a fair amount of it with perhaps some overlap with traditional or regular medicine. There are temperamental risk factors, environmental risk factors, and genetic and physiological risk factors as well. So, people with maladaptive personalities, we've talked about personality disorders very, very briefly. Those sometimes are the banes of physicians' existence, but they can be more associated with functional neurological disorders. Environmental factors such as a history of child abuse or neglect, very stressful life events, other traumatic events can also be triggers, and genetic and physiological factors such as, for example, epileptic patients who may also have comorbid paroxystic non-epileptic seizures. Prognosis actually is much more favorable in younger patients. Shorter duration of symptoms, an acceptance of the diagnosis is certainly very key. In younger patients, having family members who are accepting of the diagnosis too. I don't think it's ever been studied, but I think it would be very interesting to study how the physician's ability to communicate what the diagnosis is might, I suspect, facilitate the acceptance of the diagnosis and then help with the prognosis, and as opposed to it's all in your head. But it's never been studied. I don't have time to study that now, but I think it'd be very interesting to try to study it. I'm going to come to actually one study that was done where they trained physicians in the communication aspect for functional neurological disorders, but it'd be nice to reproduce it. Here, you're going to see anyway, it's interesting. Negative factors, do you mind going? Wait, thank you. So negative factors for prognostication include those maladaptive traits, some comorbid physical disease, and receipt of disability benefits. Particularly for adults, it becomes very problematic. And particularly in neurology, where you can sort of quantify disability, explaining to a patient that they're not actually disabled is very difficult when they're already receiving insurance benefits. And this is where, in fact, trying to find, build, and create a multidisciplinary team with a psychiatrist, a physiotherapist, a kinesiologist, and a neurologist, or a physiatrist, so a doctor in physical medicine, would actually help to reduce this number, as opposed to having patients shop around and shop around and shop around. And oftentimes they're not open or honest with how many times they've seen other physicians, and then oops, something slips, or oops, something slips, and you sort of piece together things. Thank you. Bless you. So there are certain culturally related issues which come on board. So for example, in certain cultures, and this is where I think it's important to be well educated and to have perhaps either patient advocates who can explain this, but in gastroenterology, for example, in certain cultures, it's much more common for women to vomit when they're pregnant, and vomit and vomit and vomit. And it's actually not a hyperemesis due to pregnancy. It's this sort of cultural way of saying, I'm pregnant. And this was explained to me by, yes, yeah. So frankly, I had never heard of this before. But it was explained to me, and it's sort of a cultural thing. And if you take it in the context of the culture, it's understandable, and it's a way of announcing that you're pregnant without being pregnant. But aside from that, in general, you cannot fully say, something, oh, it's just cultural, that this person is not getting up, or it's just cultural. You really have to go to as many lengths as you can to investigate, to identify, to understand the patient's diagnosis, be it organic, so physical, or a mental health issue. Functional neurological diagnoses can coexist with other diagnoses. There have been times when I've been asked to see young patients in their early 20s with a presupposed psychotic disease. In fact, it's been an autoimmune disease, not just the one that seems to be very trendy, which is NMDA receptor encephalitis, but lupus or other things. And you have to really do your due diligence. Physicians who say that there are some minor inconsistencies with a history or physical exam, you really can't just poo-poo it and say, no, this is functional. You have to do your due diligence. And you can't pigeonhole patients either to be psychiatric or medical, and the two are not mutually exclusive. There are also times when it's important to reassess patients if somebody is not evolving properly. There are times when either a home care nurse or a social worker has called me up and said, something's not right. This is not how somebody is supposed to evolve. I mean, the story of the patient who was depressed from this morning and who had headaches and more headaches and more headaches. No, I have patients in their 80s who have what looks like one type of headache, and I've investigated them for some of the more dangerous types. If they keep coming back, well, I'll reinvestigate them, within reason, but there are certain things that you can do to say, well, what is this? What am I missing? Is there something wrong? I think it's very important to be humble in everything that we do to really get a good handle on everything. In functional neurological disorders, as with a lot of patients we see, there's a lot of anxiety, particularly panic disorder. There are depressive disorders, somatic symptom problems. Personality disorders happen to be particularly common in functional neurological patients than compared to the general public, which I think is really important, and it makes it such that many physicians don't want to see these patients. Psychiatrists don't want to see these patients. Neurologists don't want to see these patients. Family physicians don't want to see these patients. It makes these patients much more vulnerable because they can't get a diagnosis. They're not prepared to necessarily accept the diagnosis if somebody says it's all in your head. They get more investigation than they're supposed to. They have difficulty creating trust links with the people they're seeing, and it makes them doubly more vulnerable. It exists in the pediatric population as well, typically more so girls than boys, 10 to 15, 14 years old. Often they have pain symptoms, not exclusively, but they're polysymptomatic, so they'll have, fatigue and pain and lethargy and sometimes loss of motor function. I see it a lot in the younger headache population, where they'll come up with every so often different types of headaches in addition to their fatigue, Oftentimes they're a perfectionist child, very, very academic and sport and cultural, and they volunteer, and there's a social life, and they're politically active. And like you look at them and you'd be like, I'm out of breath just looking at them. There was one epidemiological study out of New South Wales in the UK, which showed that it was about 3 to 4 per 100,000 under the age of 18, which I think it's actually quite significant. How can we explain this to patients in a way that they understand? So the person who wrote the volume on functional neurological disorders in the Neurologic clinics, it's this Bible, sort of this ongoing textbook. It's Dr. Josh Stone out of the UK. And his explanation, I think, is excellent. So he says the hardware is all right, it's the software that's the problem, and oftentimes people understand that. So basically, your brain is structurally okay. And oftentimes, I will start a discussion with them by saying, as long as they actually come back into the office, which I think it's important to create the space, the safe enough space that they'll come back to listen. You don't have cancer. You don't have multiple sclerosis. You don't have Lyme disease, although that's a hard one to convince them sometimes. You don't have other co-infections. You haven't had a stroke. You haven't had a bleed. I'm very reassured. The structure of your brain is great. It's the hardware that's a problem. It's the connections. Now, anyone who does, Software. Well, thank you. So it's the connections, the programming that's off a little bit. There have been studies that tried to look at functional MRI in functional neurological disorders. It's really early stages in the research, and I don't think it's come up with anything really, except for perhaps that there's some problems, perhaps involving the limbic system. But studies with evoked potentials, visual and somesthesic and auditory evoked potentials have really come up negative so far. EMG is particularly used to rule out problems, neurological problems, as opposed to rule them in. Some treatment approaches have tried to use hypnosis to help. I don't think there's we're still so sure. Hasn't been that effective necessarily. There's a neurobiological model which is being used, and they're trying to understand whether or not stress-related neuroendocrine and stress-induced changes in the hypothalamic, pituitary, and adrenal axis might be played upon in order to adjust and sort of resynchronize things. But this is really early stages of research. I'm going to skip this one, because I really want to make sure I have time for my colleague. Oh, super. Okay. This is one thing that I'd really like to discuss, and it's I touched a bit yesterday this morning in a comment about care and establishing a relationship of trust with a patient. In order to be able to have the patient be as receptive as possible to a diagnosis of functional neurological disorder, you really have to build a relationship of trust. And you need to assess the patient properly. One of the things that we use in order to assess the patient is the neurological exam. And part of it actually is you're trying to make sure that whatever item of being that's a problem, can I actually make it work? Can I prove to myself, can I prove to the patient that it in fact works? So if they have a paralyzed arm, how can I get it to work? If they have a tremor, how can I, use my neurological exam to show them that the tremor is actually not what they think it is? The assessment itself plays a role in the treatment of the patient. It sets the tone for future interactions. You have to create a collaborative setting in order to invite the patient to share confidences that they may not share with anybody else, right? You want to try to understand them as best as you can in order to address any underlying concerns. Do they feel safe at home? Do they have people they can reach out to for support? One of the things that I think is most important, and I'm probably preaching to the choir here, but it's very important to show to patients that you care, that you're taking their problems seriously. I've seen the nonverbal expressions of physicians' patients who don't give a crap about the patient, and you've seen it on their faces. Like this is, they're the ones who don't necessarily step into the room to interact with the patient, but just stand at the door or stand at the foot of the bed, as opposed to coming in, as opposed to being at the patient's side, as opposed to sitting down on the bed. Thank you. So in searching for clues to the patient's diagnosis, I think it behooves us all to have both ears open. Listening to the patient is essential. Some actually have previously been diagnosed with functional neurological disorders and have labeled it as something else completely. They may have described previous paralysis, which was not diagnosed with anything in particular. They may have other somatic complaints or have been diagnosed with irritable bowel syndrome or chronic fatigue, painful or heavy menstruation without an underlying structural cause, unexplained abdominal pain, chronic back pain. I watched the 15-year-old daughter of my husband's friend as she's now going to go in for exploratory surgery. And honestly, I don't think anybody has actually looked at the family as a whole. One child has been suicidal. Both kids have ADD. Both parents have ADD, but undiagnosed. I mean, I'm watching this from a distance. The child is 15 is going to have exploratory abdominal surgery because they haven't figured out what she has. She's a hyper-perfectionist, but has, because of her dyslexia and her learning disabilities, has never performed to the highest of her potential, I think. That's despite tutoring, et cetera, and she really wants to be a physician. But I don't think anybody, even though she's followed by the pain clinic in a Montreal hospital, nobody has sat down and looked at the whole family as a whole, has looked at the dynamics, has looked at the other children in the whole context. And she's going in for exploratory abdominal surgery. Like, honestly, it's just, people really have to listen, even in pain settings, even in pediatric settings, it's just very distressing. So what I like to do with every patient, but I think which is more important even for functional neurological disorder patients, is start, as most people are taught, let the patient speak without interruption. Let them get it out. If you time the interview, you're starting off bad. If you interrupt them after a minute, you're starting off bad. These are often patients who come in with a full list, who come in sometimes with a little support group, sometimes alone. You see the anxiety on their faces and on their family members' faces. But just let them speak without interruption. Oftentimes they say, let me start from the beginning. And they may want to give you a chronological history, and that's okay. Listen to it. Write it down. because these are sometimes the patients who also come back with complaints afterwards. Making a list of the symptoms is important. Organizing it in a chart is important. Sometimes, as I said, there's a litigious risk. More so in the US than in Canada, but in Canada, as somebody else has mentioned, it is increasing. Ask patients about pain, memory issues, fatigue, dizziness, sleep, depressive symptoms, appetite, either hyperphagia or anorexia. Performing a complete review of systems is important. I know that, in fact, some people try to avoid completing a review of systems in such patients because they say everything will come back, including bright green stool. But in fact, it's important to go through so that patients feel that they're being heard. And that's such an important link to maintaining and creating a trust relationship with patients. Ask them if there's anything else. I want to make sure that I know everything that's bothering you. These are not patients that'll be in and out in 5 minutes or 10 minutes, but providing a sense that your evaluation is complete is essential. You're building and creating a space for collaboration. You can go ahead, it's okay. Listening to patients for key words, I think, is very important. Asking about dissociative symptoms, such as altered level of awareness, sensory motor function alterations, emotions or thoughts during an event, memories, even identity can be perceived as disconnected during an event. Listening to key or cues such as I felt strange or weird, I was floating, I was there but not there, I could hear and see but I couldn't respond, I could hear voices, I felt a certain way. I was looking at the world through a glass or a veil, I felt cut off or distant, objects felt smaller, flat, or cartoon-like. These are all sort of keys that can help clue in to a functional neurological disorder, obviously not to be confused with epilepsy. All these patients will get an EEG. All these patients will get like an MRI once. They will all get a thorough neurological exam, but it gives you little clues as to what else might be going on. More important than, let's say, Freud's approach of looking for a cause of trauma and associating it, I think it's more important to even ask the patient, open the door and say, what do you think is causing this, right? Because if you don't address what they think is causing it, you won't be able to convince them otherwise, and they'll just go to somebody else. I had a patient who's been followed for episodic migraines since he was 8. It's a guy, he doesn't have a monthly cycle, since he was 8. And he came in to me and said, I think I have idiopathic intracranial hypertension. And I said, okay, how come? Let's talk about it. And it's very important. If I didn't spend those few minutes, he would have gone to somebody else with the same thing, and so on and so forth. I love Levinthal's common sense model of illness. So just understanding sometimes that something like back pain leads to painful experiences, which leads to a fear of movement or injuries, leading to avoidance of further exercise, which leads to disability and disuse, and then to depression. So oftentimes my chronic migraine patients will say, why are you going to try to put me on an antidepressant? And I'll say, no, but it's just all to sort of, one treats the other. Somebody who's had chronic pain for a long time probably has underlying depressive symptoms. You explore those symptoms. And then in fact, 6 months later or 3 months later, they come back and they're feeling much better, but you've done a multi-pronged approach, because it's not just, a shotgun, I'm going to do this, or I'm going to do this, or I'm going to do this, or I'm going to do this. You actually have to take the whole person and address each issue. Another important thing, which is a tough one, is to ask patients if they actually believe that all the tests have come back negative. There are patients who don't believe it. We'll say, but with the MRI, or what does this mean, or what does this mean? What is the ventricle? Well, it's not a problem, the ventricle. Let's go through it. Let's show you. What does this mean? What do you see? Are you sure? With Lyme disease, it's a challenge, for example. right now. There are cases of Lyme, and there are cases of people who think they have Lyme but don't have Lyme. It's, do you really believe that it's negative? Do you want to go shop more? You know, how can we try to keep the patient with us as opposed to shopping around and perhaps exposing themselves to more risks with another physician who is just going to try to shut them up and order more tests? When I approach a patient like this, and you're trying to assess a patient for psychological issues, and they've come to you specifically for what are physical symptoms, you cannot come across as trying to do a psychological assessment. Because if you do, they're going to say, you were like the other one who said it was all in my head. And then they shut you out. And you can't build a trusting relationship with them if they're going to shut you out completely. So if you come across as being too blunt about questions of depression or anxiety, it's really counterproductive because they just shut you out completely. If they're coming with a parent or a family member or a child, everyone's like, well, you know, what is this? You're not taking me seriously. So it's very important that you need to show patients that you're listening. Somebody else who talked about having your nose in the book is useless, your nose in the chart is useless, your nose on the screen is useless. Being sympathetic is extremely important. Being empathetic is important. Statements like, it must be very difficult to live with all that pain. How are you coping at home? How are you coping at work? How are you coping with your family are essential. And deal with patients' frustrations head on. Patients shouldn't be leaving an office going to, or you know, a patient-physician encounter and going to write on the blog that they were frustrated, that they were anxious, you know, coming out of an oncology appointment, feeling that it was all on them. It shouldn't. The onus should be on the healthcare practitioner to have been trained adequately to be able to run an interview, to be able to run an encounter, and to be able to actually make sure that the patient is leaving with everything addressed. Otherwise, they come back and they come back. My job is to do myself out of a job for certain things, like headache, like chronic headache. It's very important to watch body language and posture and tones of voice, avoiding to appear bored, hostile, or angry. I know it's like the end of the day, people are nodding off, and that's okay. But in a patient encounter, it's so important not to appear hostile or angry or bored. Asking for validation is really important. Am I getting this? Rephrase what patients say. These are things that are taught in medical school. They aren't reiterated in residency, but they're essential. Am I getting this right? Did I understand? Correct me if I'm wrong. Perfect. Most of the time, functional neurological disorder is not diagnosed on the first encounter, although sometimes there can be a very strong suspicion. And it's really important to be careful of the pitfall of misdiagnosing something that's neurological as functional or vice versa. So it's important to have, in French we say, une ouverture d'esprit, really to keep an open mind. There are oftentimes comorbidities, and as I said, probably between 40 and 60% of my practice is overlap, and that's okay. That's okay, you can keep going. So I mentioned and I touched upon treatment already. Communication is essential. Avoiding to label patients as difficult, as frequent flyers, is very important. It's important to keep your eyes and ears open for complexities such as malingering, where there is a secondary benefit of being a patient. And practicing sentences like, you have something that is in keeping with, let's say, Parkinson's disease, or you do not have something that's in keeping with Parkinson's disease. You do not have multiple sclerosis. You do not have a brain tumor. These are reassuring to me. Take the patient seriously. This is a serious diagnosis. So give it a label. Tell patients they have something called functional neurological disorder. Explain the rationale that the hardware is okay, it's the software that's the problem. Provide an opening for discussion of how the symptoms arose. You can try to explore different elements from what you've heard from their history, bring them back. I often explore with them the reversibility, right, so that they can get better. And certain studies have been shown that, referring them to certain self-help websites, I'm going to actually list one of them, to physiotherapy, psychotherapy, and sometimes psychiatry, although not always. It's very hard to find psychiatrists who have a real interest in this. There was it was a nice study, but it was very, very small. It was 23 neurologists who underwent a training protocol in 2010 with Hall Patch and his colleagues. And basically what they did was they trained 23 neurologists in a protocol. I mean, it wasn't really case controlled, but to explain to patients that their diagnosis is real, that it has a name, that there are many different factors or causes, including psychological factors, and that there's a treatment, which in this case, they referred patients for psychotherapy. And in this was a study of paroxystic non-epileptic seizures, so pseudo-seizures. 63% had a 50% reduction of pseudo-seizures at 3 months. 14 were in fact seizure-free at 3 months, which is really nice. And many patients also had subjective feelings, of feeling listened to, being relieved. Very few felt angry by this, because actually, I don't know, assessed whether or not patients felt angry at being told that it was functional, that it wasn't a neurological diagnosis per se. Very few felt angry. Over-investigation provides a very short-lived reassurance to these patients. Doesn't improve prognosis, which I think is very important for people to remember in every field. Tailoring to the approach to the patient is essential. There's no one size fits all. And different approaches required for a first episode or a transient episode. It's really essential that it's dealt with quickly, because as I showed with one of the first cases that I discussed, she really became chronic. Both cases, in fact, became chronic because they were lost to follow up. So if you guys want to take down the written information, neurosymptoms.org is an excellent resource for patients. Excellent, which doesn't dumb it down, but validates it and really explores the idea that it's a software problem and not a hardware problem. I just go back for a second. And the other one is nonepilepticattacks.info, also a very good resource for patients, providing very accessible information. I often try to co-follow these patients with psychiatry. It's hard. In my center, there aren't very many who are interested in co-following these patients. You can go ahead. And the prognosis is problematic, generally poor if the symptoms are motor, and generally poor if the patients are getting any secondary benefits, such as insurance or CSST or SAC stuff. And if they haven't been able to go back to work, essentially. I'm going to go ahead. So I'm going to return to the two cases because I just want to finish up. Yeah, thank you so much. So case 2, which was this lady in her mid-50s, the Tunisian lady, the single mother with 2 kids. She had convinced this GP. She had 2 normal EMGs, one with me, one with a subspecialist in neuromuscular disease. She stopped coming to follow up when I really insisted that she come with a family member for corroborative evidence. She stopped coming to work up. I was insisting on an EEG, and I was encouraging her to get rid of her wheelchair because she was seen by a physiotherapist in our center, and she wasn't collaborative with that. So she ended up getting followed by a family physician at a CLSC and was completely lost to follow up with me for 2 years, at which point they contacted me to find out what her ultimate diagnosis was. Why did she need a wheelchair and a hospital bed? And in fact, 2 showers per week, which I have trouble getting some of my Parkinson's patients 2 showers per week from the CLSC. So I said to the family doctor, please have her come back for one last follow-up, just to sort of, so I could wrap it up. She came in with a manual wheelchair, and for transfers she was using a walker. And I asked her, can you talk to me about why you need the showers? Just, what's going on? Because, ultimately, if she's able to support herself for transfer, she could transfer onto a chair in a shower, for example. And she said, "Doctor, when I'm under the water, I'm drowning." So we explored that a little bit. And the reason she escaped Tunisia was because her husband would torture her by holding her under the water. So in fact, just had I even managed to create a better therapeutic link with her in the beginning, there's a possibility that I would have been able to really steer her in the right direction. She was referred twice to psychiatry by me, and nothing ever stuck. But had I been able to address it much earlier, she wouldn't have had to use so much CLSC resources. Everything was misdirected because, in fact, it wasn't addressing her ultimate problem which was she was terrified of taking a shower by herself because of these PTSD symptoms. And she was very, very refractory, unfortunately, and lost to follow-up. The third case, which was the young mid-40s patient who had the acute neurological symptoms that looked like a stroke, but which did not fit. She had 2 negative MRIs. She was refractory to physio on the ward. She remained essentially hemiparetic, so too weak to walk on her own, but she was able to move her muscles. And she ended up going to rehab, inpatient rehab. The toughest part was that her symptoms did not fit with a stroke, didn't fit with a stroke syndrome. There were 2 MRIs which were exclusively negative. There were many inconsistencies in her neurological exam. And we talk about copy and paste. These are not electronic medical records. Everybody in the medical field and in psychiatry kept writing down stroke, stroke. And there were 4 of us neurologists who rounded in sequence, and we kept saying, this is not neurology, this is not a stroke, this is functional neurological deficit. And it was the most frustrating thing, particularly since it was mostly the medical students and the residents who were very legibly writing stroke, and then we would come back and like little scribble scrabble and say, this is not a stroke, this is not a stroke. She developed capsulitis, so she developed an inability to move her shoulder because of this, and this was exclusively functional. Yeah, so, and it was very, very problematic. Yeah. Take home messages, stick to your guns, work on communication skills, build relationships with trust, and listen to patients. Keep your eyes and ears open. Thank you.
So the moment you've all been waiting for, now you're going to know what I do. Before we start, could you please stand up? Just for a couple seconds. Just stand up, do a moonwalk, move around a little bit, because I have lots of stuff to tell you and I want you to be awake. Okay, thank you. So now you're finally going to know what I do. You've been wondering, who is this guy with the weird name? So, no disclaimers. So, I'll present to you the Montreal, what's called in the literature now the Montreal model. And so it's our model of patient engagement, what we call patient partnership. It was started at the University of Montreal. And then I'm going to, if I have time, show you some concrete examples of what we do, because I thought that hearing the conversation since yesterday, I think that it might interest a few of you. So a bit about me. First of all, I have hemophilia, which is a lifelong illness you're born with, obviously. So I started out as a chef, as a cook. I did Italian cooking, actually. And but I had to reconsider my life choices because obviously it's a high-risk job for someone with a bleeding disorder. So I went into academia, but I was still working in restaurants. And one day I had a very bad internal hemorrhage in my ankle, and so I decided to sort of come out of the closet, if you will, and I went towards my patient community, the Canadian Hemophilia Society, and I started getting involved, meeting other people with the same illness, because I had grown up without knowing anyone else with hemophilia. Then I met Vincent Dumais, who's the guy who started this program at the University of Montreal, and now I'm doing this full-time. So this is just to show you very quickly my annual bleeding rates. So this is out of an application I use for self-monitoring as a hemophilia patient. And you can see this is a 2011. I had, you can't really see here, but I had almost 30 internal hemorrhages a year. in all kinds of different places. I mean, the hips, the ankles, the head, the thighs, knees, everywhere. I would bleed this is more than twice a month. So imagine you can't go to work, can't go to school. You know, it's very depressing, painful, difficult, and causes long-term damage. Then last year, 2018, I went down to 7, which is a huge difference in quality of life. And this year, I've had 2 so far. So this is just to show sort of my progression personally. So now I work in this field, patient engagement, but also the impact it had on my health. So how did the Montreal model start? So it started in 2010 with the encounter between a clinician and an experienced patient. So that was Vincent Dumais, who's a hemophilia patient, who was also an HIV activist because he was infected by the tainted blood crisis in the 80s with hepatitis C, hepatitis B, and HIV. So he was a very experienced patient and fortunate to be alive. And he met, professionally, he met the dean of the Faculty of Medicine at that time, Jean Rouleau. And they realized that they had the same vision of healthcare for tomorrow. So then they created what was called at the time the Bureau du Partenariat Patient, so the Office of Patient Partnership within the Faculty of Medicine. So this shared vision of the dean and the experienced patient led to the creation of a highly legitimized faculty unit dedicated to patient partnership, and that's really our strength when we go to international conferences. That's what sets us apart, is that we have this actual academic unit which supports us. And then it started with a deployment in education in medicine, so in medical education, and then the health sciences, and then eventually it spilled out to the healthcare establishments. We started getting more and more demands from healthcare establishments to help them implement patient partnership within their structure. And so eventually it was too much for an academic unit. It was sort of beyond the mission of a university, a faculty of medicine. So then we created the Center of Excellence at the CHUM Research Center, which has the mandate to implement patient partnership in research and in the field, so in care and in quality improvement, etc. And so it was coined the Montreal model because some colleagues went to the Macy's Foundation and they presented the patient partnership model, and there were other models of patient engagement presented, and then everyone started referring to it as the Montreal model, and that's how it got published as the Montreal model. So why are patients indispensable partners? They're not only clients, but also an integral part of the quote-unquote production chain of health. So one thing that we like to point out is that in industry, it's been normalized for a long time for clients and consumers to be a part of the definition of industry. But healthcare, however, has been an industry which has defined itself for a long time up to recently without its clients. This is a little bit of the background, just to show that patient partnership did not just sprout out of nowhere. So obviously there was from 45 to 70, the biomedical, the prevalence of the biomedical model. The 70s and 80s was a period of debates with debates on body ownership, for example, talking about abortion. And then the 80s, 90s was a period of crisis, of course, HIV, tainted blood. In the 90s, 2000s, more a period of conflict. Someone mentioned the legalization of healthcare, being sued, militancy, etc., and a shift towards a consumer approach. And then from the 2000s, there we consider that we're in sort of a bit of a new era in the way we consider healthcare, and you have the emergence of concepts such as shared decision-making, self-management, patient experts, and patient-centered approaches. So some facts about today's healthcare system. So first of all, in the Western world, over 50% of people live with at least one chronic illness. What does this mean? This means that these 1 on 2 people who walks into a clinic already has experience of the healthcare system, already has experience of living with illness. This is from a book from Angela Coulter, who simply highlighted that the average time spent in a clinic for someone living with a chronic illness is 5 hours a year. However, anyone living with a chronic illness, such as hemophilia or anything else, will tell you that you're constantly managing your illness, and your loved ones as well, everyone close to you. We're always constantly living with the illness. You can't escape it. So what does this mean? It means that we wonder how come non-compliancy remains a problem. So non-compliancy rates are still high and are still identified as being a major economic issue and also just a healthcare issue. What we think is that doesn't mean that patients are necessarily bad patients, but maybe we have to rethink the way treatment plans are made. So this is the way we present the patient partnership in care model. So here on the lower one, you can see is what we call the paternalistic model or the traditional model, where the doctor is king. There's no interprofessional collaboration. The patient is completely outside of the process and is just receiving a service. In the middle, we have the patient-centered approaches, where we start to have the patient participate more. This is when we start to consult, for example, the population of a healthcare establishment to get their opinion on certain elements for quality improvement, for example. However, the patient is still at the center. He's still not considered part of the healthcare team, and also there's also still a weak interprofessional collaboration. So this is when we talk about working in silos, for example. That would be it. And then the nuance with the patient partnership model is that the patient is recognized as an actor of his or her own care. So that it might seem small, but it's a nuance which has gone a very long way. This also allows a much stronger interprofessional collaboration, because a lack of interprofessional collaboration in the healthcare system is something which makes no sense to a patient. It makes no sense. Why should I have to re-explain to this other, to my physio, why don't you guys talk to each other? To us, it doesn't make any sense. So what we found is that when we bring patient trainers into interprofessional collaboration workshops, you see a much higher level of collaboration between the students. We'll get to that later. So some core values of the model is free and informed decisions, recognizing and mobilizing what we call experiential knowledge, so knowledge based on that comes from the lived experience of the patient, developing healthcare skills in the patient, recognizing the patient as a member of the team, and mobilizing one's life project within the treatment plan. And by the way, when I say patient, I include family members as well. So, also, patients are not only an accumulation of needs, but hold a very rich knowledge. So, of course, healthcare professionals are the experts of their profession. However, this model means that there is a recognition of a certain expertise of living with illness. So we have to recognize the complementarity of these two perspectives and these two expertises, and these have to constitute shared values on which the model of partnership in care is built. So for us, the patient of tomorrow is recognized as a full actor of care, owns their medical information, is connected through self-monitoring, better informed with using social media and online diagnosis, understands the value of evidence-based medicine, is a better decision maker in their own care, and helps to inform a healthcare environment that is ethically and socially responsible. Healthcare professionals of tomorrow are enabled by technology to humanize the way they provide care. They work in partnership with their patients, so they work together. They're returning to the art of medicine and not only the technology. They are working in communities of health, communities of practice, and they also help to inform a healthcare environment that is ethically and socially responsible. So patients are also not only users of the healthcare system, but also observers who bring a unique perspective of the system. So what we found is that when patient partners are involved in, for example, quality improvement or security or any type of project or research projects, what we find is that we're able to leave the sort of traditional hospital-centric view. By the way, you know that healthcare professionals were not always invited to these committees. This started in the 2000s. Exactly. So what we're saying now is that bring also that patient perspective. And we can leave this hospital-centric view, which is based on the assumption that people come in when ça va mal and then they leave and everything is fine, to more of a systemic view of a patient trajectory. And in healthcare management today, at least in Quebec, I know we're going much more towards thinking about the patient trajectory rather than working in silos and in a hospital, centric view. So how do we approach cultural transformation to integrate the patient voice into the healthcare system? How do we try to achieve this? Because our goal is cultural transformation. We know that you can't just impose it. You can't say, well, now you're going to do it like this, and it's not our idea anyways. We don't want to, it doesn't, the goal is not for it to be some kind of magic recipe that you brandish and say, oh, well, we got a patient partner, so everything's fine. The idea is just to change the basic fundamental culture of the healthcare culture to allow for patient engagement and to allow for people to partner with their healthcare professionals and be more involved in their own healthcare, and then also have a higher degree of involvement and partake in the decision making regarding their own healthcare. So we're looking to develop a partnership culture throughout the healthcare system to deploy this vision of partnership in care. By working at different levels of the healthcare system, so governance, management, organization, processes, programs, and also we have many different documents and tools and concepts that help us structure this patient partnership voice. So of course, another element is that patients and families are more and more connected. So once again, we're looking really at the healthcare system on a macro level. Remember, you asked me in the car, are you thinking about the system? So we think a lot about the system. So we work on the public policy level. We worked with the ministry. They recently published a guide on partnership with users. We work on an organizational level. We've accompanied many healthcare establishments in opening, for example, Bureau du Patient Partenaire, so patient partnership offices within their healthcare establishments. And we work also at the clinical level with different types of initiatives with clinical teams. And then we also work in in teaching. So we have over 14 programs, and I'll show you some of them. Partnership in care, so we've had over 40 pilot projects in quality improvement, governance in healthcare, public policy definition, and partnership in research, where, for example, we support the Quebec Sport Support Unit. We work with Réseau 1, and we've recruited and trained many patient co-researchers, and we have many researchers in our team as well. So it's just the beginning. Obviously, we're tackling now more and more issues of the future, if you will, or the present. Social media, democratization of medical information, Dr. Google, artificial intelligence, self-diagnostic tools, connected tools, personalized healthcare, etc. We're always getting bombarded with solicitations to work on such projects. Artificial intelligence is funny because there's loads of money out there, but nobody knows really what it is or what are we going to do with this. So you have all these groups that are funded but don't really know what's happening. So mobilizing networks for large-scale effects. So once again, the idea of working on a systemic level. We're not alone, so it's really a change on an international scale. There are similar type movements all over the world with different names. I was just a couple weeks ago in Italy presenting it at the University of Modena, our model, and they did their first interprofessional collaboration course with patient partner trainers and everything, so they're very excited about that. We're working with NHS Tayside in Scotland as well, the Autorité Régionale Parisienne, the French Paris regional authority has just, we have 2 colleagues over there right now. They're opening a regional patient partnership office there. So it's a movement which is taking a lot of importance on the international scale. And this is just sort of, just to illustrate that, so the World Health Organization has a framework on integrated people-centered health services. And finally, one of our major challenges is building the science of partnership, because we know that actually what we do on the field is going much faster than what we're able to publish on the side. So we've published more than 80 publications within our team since 2010, and we've done more than 450 national and international conferences, which is incredible to me. But it's always difficult to keep up. So people go look at, for example, what we've published, and then they see things from a year ago. But in the last year, we've been doing, dozens of projects, and it's hard to keep up. So it's a multidisciplinary project, a collective scientific project. We have in our team and in our collaborators, we have people that work in ethics, and we have citizens, patients, caregivers, people in design, philosophy, anthropology, public health, sociology, political sciences, law, humanities, social sciences, of course, medicine. We're in the Faculty of Medicine, management, nursing. So it really a wide spectrum of perspectives that are working together on this project. So the center itself is composed of about 20 full-time employees that are from all these various backgrounds. I'm one of them. It's divided in it has sort of four poles, four focuses. One is the school, that's what I'm responsible of. This is training and education. Then we have the network, which is trying to make communities. So there's a community of practice on patient partnership you might know of in Quebec that has managers from all, I think, most of the healthcare establishments in Quebec, for example. Then there's we have the lab, where this is led by Dr. Antoine Boivin, who does research and evaluation, and then we have a strategy pole that thinks about sort of systemic change. And so some key structuring elements are training, evaluation, recruitment, and strategy. We found that one of the key success factors is recruiting the right people. Like I say in my trainings, not everyone is made to be a postdoctoral fellow in biomedical science. Not everyone is made to be patient partner on a committee with a group of postdoctoral fellows in biomedical sciences. So some of our partners, as you can see, Quebec, national and international, and we're not bored. We're not missing work at all. Okay, so now I'll give you maybe just some more concrete examples. So this is the medical cursus at the Faculty of Medicine of University of Montreal, and these are all the courses that they have throughout their trajectory, which include patient trainers. So as you can see, the white ones here are interprofessional collaboration courses, les cours CSS, Collaboration en sciences de la santé et partenariat patient, that are co-facilitated by a professional and a patient. Okay, we have a community of 300 patient partners, trainers at the University of Montreal. It's a big project. And then these are other courses here that have patient co-trainers. So this, as you can see here, you have 1,500 students every year that go through these trainings, and they're all interdisciplinary. And then we have a committee that basically mixes up the students into small workshops, interdisciplinary workshops. So it's over, I think, 6 faculties and a dozen departments. It's a huge thing. So then these are med students, right? So the préclinique, then the internship, externat. They have 2 clinical ethics workshops that are also co-facilitated with patients. And then during the residency, they also have 3 workshops that are co-facilitated. And these workshops are on their lieu de stage. So the patient and the patient, actually, we do the workshop in the hospital. So they don't go back to school. They're really in there where they practice, which makes, I think, a big difference. So just some examples. Here's a workshop called Power and White Coat. So it's a group of 20 medical students. It's a discussion over power. What is power? Who has power? The doctors, students, patients. And the idea is to develop students' reflexivity and to have them think about about power. Who has it? What does it mean? And so different types of power are explored through 5 known movie clips, and then there are discussions within the group with the patient and the healthcare professional. Here's another one. This one is clinical ethics. So the goal is to develop clinical reasoning and reflexivity, to promote the practice of partnership in care between HCPs and patients, to explore the complexity of certain ethical issues, and to share and discuss difficulties that they live through their internship. So students share those difficult situations that they're living during the internship and discuss with the patient and the professional, who will also share difficult situations they've lived, and just to bring them to reflect on those situations rather than just absorb them and then reproduce them later on. And then this one is on narrative ethics. It's to, once again, develop reflexivity. There's a writing exercise. A short movie clip is viewed. And students and patients as educators share their perspective, and they compare contrasts emerging from the stories. This is the video clip. I wanted to show it to you. So if you could please play it. Can you hear?
Hey.
Mom, I did something really bad, and I really stuck a Q-tip fart on my ear.
All right, slow down, honey. Look, it's Dad. Okay, slow down.
I think I'm deaf.
Slow down, honey.
I can't, because I heard air hiss out the hole. I heard air hiss out of it, and I think I really messed it up.
What's going on?
It seems Hannah stuffed a Q-tip very deep into her ear hole.
Nothing
Is that accurate,
smaller than
Hannah?
an elbow in there, ever.
That's it. Nothing. Did you hear your mom?
Ever.
Ever.
I have to go to the hospital.
What's she saying? Oh my, who's going with you, baby?
Who's gonna go with you, honey?
Any one of my, 12 to 15 very close friends. That's not why I called you.
Hannah, don't mosey. Go to the hospital.
Well, you must be feeling pretty silly. What were you, digging for gold?
The Q-tip is still in.
I'm not blind, my dear. How deep were you going?
I was having a little trouble hearing,
Well,
so I was
nothing like you're having right now. Well, I'm going to look into your ear now, okay?
Thank you.
Hold still.
I've just been having a little trouble with my mental state.
You're kidding.
These days, I have a lot of anxiety, and I didn't think that stress was affecting me, but it actually is. And so I'm not saying this was an accident, but I was just trying to clean myself out, and I got a little bit.
I can't see much down your ear. There's too much blood. I'd say it's an abrasion, an abraded drum. If you're still having a problem hearing, by the day after tomorrow, you should see a specialist.
Okay. Do you think maybe you could clean the other one out, just because it's feeling a little
I
uneven?
don't clean ears, my dear. I'm just going to put some antibiotic drops if you lie on your side, please.
Okay.
Thank you.
Maybe you could just look at the other one, not even clean it.
There's nothing wrong with the other one.
It hurts so bad.
Really? That bad?
Really bad.
Wow, I done.
Can I keep...
Okay. So that's the video clip. And then these are the questions that are asked from the students in the narrative ethics workshop. So, oh, I forgot to translate that. Sorry, that's in French. I added it this morning. So, écrire l'histoire d'un des protagonistes à partir de sa perspective. So, write the story of one of the protagonists from their perspective. Either the patient, Hannah, or the doctor, Naresh. Hannah sends an email to her parents saying, Mom, Dad, after I spoke to you on the phone, 3 little dots. And then Naresh, if you choose Naresh, you write to your wife, honey, you will never guess what I saw today. So you have to write how you were and how you behaved during the scene, and write what you were thinking and how you felt. So the students break up, they write this, and after that they present it to the group, and there's a discussion with the patient and the healthcare professional about the case and the ethical sort of situations which are in it. And I think this made me think when I think it was Suzanne who said this morning, who gave an example of being completely not beside the track on why the patient was actually there. I think this is an interesting example. So I'll wrap up quickly because I know it's getting late. So these are the interprofessional education workshops. So these are the programs which are part of these workshops. We have 14 programs. Well, 13, and psychoeducation is coming up. So you have speech therapists, social workers, physiotherapists, psychology, pharmacy, optometry, etc., doctors, dentists. So they all get together in interprofessional workshops which last 3 hours each year for 3 years. This is a busy slide, but it's just to show you sort of the progression. So the first year, it's discovering professions and patient partnership concepts. So they learn, for example, what does an audiologist do? What does a physiotherapist do? Because they don't know this yet. And that's very interesting to see them say, I always wondered what a social worker did, And then the second year, it's role clarification. So role clarification, so to be able to see when, for example, maybe our roles might overlap on this thing, and then how to work those overlaps out. And then the third year, collaboration practice and interprofessional intervention, so plan. So then they have to produce together an interprofessional intervention plan on a case that it's a plan in partnership with the patient. And all throughout these workshops, there's a patient partner co-trainer and a healthcare professional co-trainer. That are both the healthcare professional and the patient are recruited and they're trained at university, and they're paid so for their time because it's a full day. So now, last slide, I promise. So just some other exciting projects we're working on. I'm working on mostly. We have a new master's program in biomedical sciences patient partnership profile at the Faculty of Medicine. So that's very exciting, launched this year. We have a new online course called Fundamentals of Patient Partnership, which is also at the Faculty of Medicine. We have a professional certification program which we're working on and we'll release. We're going to start testing it soon. We have a mentorship program, so this is an exciting one. So a patient can, when they start their program, it's on voluntary basis, but they can be coupled with a patient mentor who will follow them throughout their whole education. And then, so they'll be able to help them with, they'll be basically, for example, the student will follow the patient to the hospital, to their meetings, to the ER, and really get that other perspective. Patient evaluators. This is also a very exciting one. So Osler and Huskies. So Husky, you know what Huskies are, a form of evaluation with stations, and they're kind of like simulations with actors. Traditionally, they're done with actors, but what we did is we said, well, why don't we put patients, real patients, instead of actors, and they can take a scenario from their own experience, and relive it, But not only that, they can also be evaluators. They can evaluate the intervention of the student. And that evaluation is worth something. So I think the first time we did it was 10% of the grade. And then the Faculty of Medicine was very scared at the beginning because they said, what about standardization? They're not actors, it's their own case. So how are we going to? But they loved it. And the next year is going to be 35% because they said, the doctor evaluators said, we were able to evaluate skills and competencies and attitudes which we would have never seen with actors. Yeah. So that's a very exciting project. They're actually doing it in Modena as well, but so it's not part of the grade. They did it as a test, and we didn't know. When I was there, I said, we're doing it too. And patient accompagnateur, so we're working with patient navigators, patient accompagnateur, père aidant, so there's like many different terms for this, but basically patients that are going as volunteers today in clinics to help other patients, help clinical teams. So this is being done all over the healthcare system already. It's been being done for a long time. So we're working with them to sort of get them a bit more legitimacy within the system, give them training programs, etc. And a new exciting project which has barely started, but so certifying patient skills. So, for example, a hemophilia patient, working with hemophilia patients and saying, what does a hemophilia patient need as basic medical skills to live with hemophilia? For example, intravenous injection. I can teach anyone how to do an intravenous. I do it every 2 days my whole life. So it's a skill which you need. I need it to live. And you need a basic understanding of coagulation. You need basic understanding of how the joints work and stuff like that, or else you won't be able to manage your illness. So what we want to do is have a sort of a little card or certification or something. So then in a case of emergency or in the ER, for example, a patient can say, I have my card of University of Montreal. I was accredited with the basic skills of, for example, a diabetes patient or epileptic. I can take care of this. And the person can say, okay, fine, perfect, give you the treatments and I can go take care of something else. Or in an emergency situation, for example, okay, you know when you say, I'm a doctor, well, if someone is having an epileptic seizure and there's a guy with the epileptic, I have epilepsy and I'm accredited, I know what to do. And this was it didn't come from us. This came from the people at Développement Professionnel et Continu who approached us, who are doctors, who said, we think this would be great. What do you think? Yeah, of course. So, last slide. This time it's really the last slide. So in the OSCEs, we made an evaluation grid for the patient. The patient doesn't have exactly the same evaluation grid as the MDs. And the last question on the grid, question 10, is a question générale. Est-ce que je ferais confiance à cet étudiant pour devenir mon médecin traitant? And that means, would I trust this student to be my physician? And that's a pass or fail, yes or no answer. And I think I really love that. I think it's a nice way to wrap up the presentation. So, any questions? Thank you very much.
The OSCE examination is an amazing concept. I work with children, and I had a great time with one kid, 8 years old, and he was saying, oh, this guy didn't pick up my pacemaker and this and that, and the way he examined me was not right, and it was very interesting. The problem is they don't do it anymore because of costs and because they had to bring an ambulance just in case that there would be something with the patient, so they shied away from it just for cost purpose, but it was a very, very great experience.
Where was this?
A Royal College for the certification of pediatric cardiology. So yeah. But my question is, I work in a hospital, like academic hospital, and administration, research, and clinic, and I have a kind of a question. They ask often about bringing a patient on board for certain purposes, and sometimes I don't think it's a good fit. So what are good fits in an hospital for patient relationship, and what are not good fits?
That's a great question. First of all, it's not necessarily always pertinent. That's a fact. And another thing is also that, especially if you're in a hospital context, we really make a distinction between user committees and patient partners. So they have different mandates. So user committees, for the Americans, I'm not sure, the Americans, do you have user committees? They're committees, we have this in Quebec, it's committees in hospitals that are there to defend the rights of patients. Yeah. Yeah, but they're not just advocates, they're actually like, they have a place in the structure of the hospital, and they have like, okay. So the mandate of user committees is to defend the rights of patients. So it's very difficult to defend the rights, and then the next day have to collaborate and partner, and so that's why we think it's important to have both. Both are important, but they're very different mandates. So that's one thing. And effectivement, c'est pas toujours pertinent nécessairement. Yeah. But one thing that we have seen is that it's not always pertinent. But one thing that we have noticed also is that sometimes people think it's not pertinent, and then they bring in a patient partner, and they're really surprised by what that person has to say. Sometimes it's things that we have lots of examples of things that nobody had thought of. But when you're coming in through the main door, it's something which might seem obvious, but it wasn't obvious to anyone else around the table. So that's the way I would answer that.
We have a patient as a committee member on our research ethics committee. So there's always a patient looking from the patient's perspective, adding that little extra something whenever we evaluate research from our research ethics center, in fact. And it just adds that extra something.
So I'm an endocrinologist, so I deal with a lot of diabetics. So the younger diabetics, we have all these new pumps and stuff which are virtually artificial pancreases, and they hack the programs on these pumps, and they have these groups where they discuss what different things they can do. And I'm wondering how technology is going to fit in with what you were saying.
Well, it's
They make the pumps go faster or slower.
so. Therapeutic education, what we call éducation thérapeutique in French. I'm still not sure what the best translation is in English, because therapeutic education is not really used, is it? But you understand what I mean. So, okay, therapeutic training. Yeah, that's a huge part of it, of course. And you know, they have to understand. Like, for example, it took me a long time to understand, you know, why it was important to infuse even if I was not bleeding, because it's to prevent the bleeding. So, you know, but I had to understand how coagulation works. I had to understand how joints work. I had to understand where the pain was coming from. I had no idea why. I had to so I think that's just a question of educating. But also, you know, diabetes is, I think it's type 1. It's like a bit like hemophilia. It's like you grow, you know, you live with it. It's the only life you know. So of course you're gonna, you know, like everyone does. Even someone perfectly healthy does stuff that they're not supposed to do. So you learn, you know. Yeah.
Hi, so I'm a nurse in DC, and I work on an oncology unit, and so I have a question for both of you, because what you were saying, Mathieu, is the ideal, right, that we have patients who care about themselves enough to be so interested. But many times I have a patient like the two of your cases who disappear, you know, they come, they get their diagnosis, they get their opioids for the week, and then they're gone, right? So what do you do for the patients that aren't, you know, I'm interested in them. I want them to be a part of their care, but they don't care to be. You know, they want to come to get the cure, to get the meds that they want for the week, or, you know, to get them over their, you know, whatever they're having. In my hospital, for example, often like a sickle cell patient wants the opioids, get over his crisis, and then move on. But yeah, how can I help my patients to, first of all, care about themselves enough to want to be part of this discussion?
One of the ways, it's an excellent question, and I think it has to be tailor-made to the situation. I was asked to see, as a second opinion, a patient with a functional neurological disorder with a very complex neurological exam, who happened to be the sister of an employee of the hospital, somebody who is well known in the hospital. And it's very touchy, and it's controversial, and it's, you know, it's a touchy thing. This person was off work for a year getting insurance payments, and it's a really delicate thing. And I think we touched upon dialoguing and sort of having a community environment in the hospital setting or in wherever you're working. And I actually called Christina and I said, can you come take a look at this patient? You know, she's not in the ER. I don't want to send her to the ER. Can you come down to my office and take a look at this patient and examine her? And then together we can try to, confirm what I'm seeing, because it was a pretty impressive exam. And I said, there's too many discordances. I really think it's functional. The first neurologist wanted to send her for a muscle biopsy, and I'm like, no. And in fact, so the two of us sat down, and then we tried to find an approach where I'm going to send her for some more blood tests, confirm that her CK is still really normal, and we'll see her again. But it's nice. I'm lucky I work in a very small hospital, a big hospital, but a small hospital. And I'm able to call upon people to help out in the immediacy. So if you have somebody who comes in and wants a quick fix, who can you think of to help you in this? You know, maybe a physician. Does this person need psychological support? Can you maybe ask a few more questions before dispensing the medication or the prescription to just grab them while they're there and see if you can address things a little bit deeper? You know, who would be the best person? Can we bring you right to the hematology department or the, you know, whatever department it is, get you the appointment that you need, have you seen quickly, so that you don't fall into this trap of, like, you know, diagnose and adios. And it's true. But so that was what it was in neurology for the longest time. You know, you diagnose MS and then they leave and you don't see them again, and then they're paralyzed, et cetera, et cetera. It's figuring out how you can just create that little relationship very quickly, so that maybe you can help them prevent another sickle cell. Well, okay, maybe you can't prevent it, but, you know, how can you better address it so that it's dealt with better the next time round? You know, just each case is different.
What I would say is, because so it's like the $1 million question, you know. I don't think it's one of those things where you're talking about human relationships, you know. The relations, this is what we focus on. It's partnership is a relationship. La relation therapeutic relationship, you know, there's no magical recipe, unfortunately. There's no pill that will make a patient super active and engaged. But I think that what you're doing here is like, you know, our colleagues that are our physician colleagues in our group are people who go to discussion groups. They're part of communities of practice that reflect on these questions, Balint groups and things like that. They read a lot on practice. That, you know, I think that being here and being at meetings like this and exchanging and having a reflexive approach, that's what we teach in the clinical ethics workshops, is to stimulate that reflection, keep thinking about it and trying to strive towards, yes, an ideal, but as long as you know, you have the right ideal and you keep striving, I think that's what I would say. Yeah.
Okay, I'm not quite sure how to ask this question, but I'm in my first year of medical school, and we actually do have interprofessional education every Friday, so thank you so much for your work. And yeah, I work with a lot of different professions as I'm going through training. And I guess you had said something at the beginning, Mathieu, about half the population has a chronic illness of some sort, and I'm just curious. I'd imagine then half of this room has some sort of chronic illness. And so how, like, being a doctor or being in the health profession does not save you from being human. And so how, I would imagine then also that half of us have been a patient in some situation. So we're supposed to be patient advocates. So what training would you provide to physicians or nurses or anybody of how to kind of tap into our own resources and our own experience as patients? In addition to your advocacy work, but just like a remembering of, like, what it's like not to have this information or not to have this knowledge, but to have the experience of being a patient, and I don't know how that can transfer in encounters. I'm not sure if you have experience in that, but yeah.
So that's another question we're asked very often. We have lots of different interesting cases, scenarios concerning that. We have healthcare professionals that all of a sudden fall sick and then come to us and say, oh my God, it changed my everything. Now I want to be a patient partner. I want to come to the committees and I want to be involved and I want to do and so that's a scenario that happens. But then we also have people who, so sometimes, clinicians that will have an illness and that will want to be, let's say, part of a committee but then they end up being with their colleagues, and it's difficult because the thing is that when people say, I would like to have a patient partner on my quality improvement committee, the mandate is to, like I said, we have lots of structuring, a way of structuring it in the sense that their mandate is to engage from their lived experience of life with illness and of the healthcare system. So if they start talking like a nurse, or like a doctor, and you know, that's not why you specifically were invited to this. You're invited as a patient expert, you know. So So we try to really differentiate. However, I know many hematologists specialize in hemophilia who are hemophilia patients themselves, and they're some of the most influential people in the hemophilia community, and they're incredibly interesting people. I'm not sure how, I think that it definitely does give you another perspective. Yeah.
One last question. So our theme is the risk of medicine. Okay, sorry, my English is not so good, but I'll do what I can. Okay, so there are many risks associated to partnership with patient. The first one is better care, more humane, because you have a real dialogue with the patient, okay? The second one is an increase of efficiency, because you don't lose time doing things that patients don't want to do, and also because you really work with them doing things that they want to do for themselves, help them identify and do those things. There is a huge increase in trust, huge increase, it's exponential. Okay, I'm working like that myself for many, many years. There is also a huge increase in compliance. Is it the right word? Okay. And there is an increase of the physician competency, and the same with the patient, and the same with the team we're working with. So this is a risk that's worth it. Thank you.
Mm-hmm. If I can just, I had a meeting with my colleagues at the university the other day. Some physicians said, why do we do this? And the physicians were saying, to humanize our job, to get back, and then asked, Mathieu, why do you do it? I said, well, look at my annual bleeding rates. That's why I do it, better outcomes. So.
If you don't listen to patients, you miss the mark completely. And what you said was if you listen to them, it actually improves your compliance rates for the patient. So if you have a chronic headache patient who says, I don't tolerate any medications, don't try to give them medication. There's a reason they're coming to a second and a third physician for an opinion. It's because if they're saying they're not tolerating a preventative medication, look elsewhere. Increase your water intake, decrease your caffeine, stretching, target the counseling based on what the patient is telling you. And I think what you said made a lot of sense.
Well, thank you all. I think the last